So good morning, everyone. My name is Taylor Cepeda. I am the Assistant Director of PR and Communications at the Medical Society of Virginia. I'm very excited to welcome Chelsea Sprouse and Dr. Brooke Rosheim for this morning's COVID-19 vaccine recommendations update. We appreciate you all and everyone at VDH for continuing to offer guidance and updates to the MSV membership. I just want to go over a few housekeeping items. If you would like to ask a question, please utilize the Q&A function at the bottom of your Zoom screen. If you have any questions that are not answered or that come up after the webinar, please email our team at memberservice@msv.org, and we will make sure that the question goes back to the VDH team and we get you an answer. As with all of our webinars, this will be posted on our website, so we will also send out an email to all members about the recording as well. We've had a few requests. And then on behalf of the MSV, I'd like to thank our attendees for taking the time with us today, and I will hand it over to Chelsea. Thank you so much.
Good morning, everyone. Thank you, Taylor, for that introduction. Today, we're going to be talking about several things, not only the new COVID-19 vaccine updates, but also give you a little bit of landscape of what's going on with COVID in Virginia and the United States, and some other little clinical pearls as well. So my name is Chelsea Sprouse. I am a pharmacist. I'm the adult vaccine coordinator within the Division of Immunization here at VDH. And we are super excited to have Dr. Brooke Rosheim on here as well. Dr. Rosheim, did you want to come off mute just to introduce yourself briefly?
Hello, everybody. My name is Brooke Rosheim. I work as a public health physician specialist on the health information team in the Office of Epidemiology for VDH. So happy to help with the webinar.
Thanks, Dr. Rosheim. All righty, getting right into it. So just wanted to give you a little bit of background about where we are today with COVID-19. So as of May the 4th, more than 104 million cases and 1.1 million deaths have been reported in the United States since the start of the pandemic. Cases, hospitalizations, and deaths, as we all know, have continued to decline, which is great, with the help of effective vaccines and therapeutics. Recently, there was an end to the federal public health emergency on May the 11th. And then also previously before that, the World Health Organization declared an end to the international concern. So continuing to focus on the prevention of severe illness and death from COVID-19, as well as hospitalizations. So now we're just going to give you a little bit of data. So as you can see here in this graph, this shows weekly rates since I believe the first is March 2020 on there. So you can see where we've had peaks, to no surprise, in the winter times. But recently, in the past few weeks, you can see a steady decline there at the far right of the graph. So hospitalization rates are the highest amongst our older population, so 65 years and older. Hospitalization rates do continue to decrease in all age groups. As far as cases in Virginia, again, to no surprise, cases are trending downward. You can see there a 7-day average of approximately 200 cases per week. And as far as looking at our health districts across Virginia, just wanted to point out here that we do have some of the darker blue, which indicates the higher case rates. So in Southwest Virginia and a little bit there in Central Virginia as well. But overall, we're seeing low case rates across Virginia. All right, when we're looking specifically at some demographics, so case rates amongst age groups, you can see there on the left-hand side. Cases are increasing as we get older, into our older populations. And then when we look at race and ethnicity, we see our highest case rates amongst Blacks and whites. And this little graph is nifty. So if you don't follow this, it's available on Nowcast, which is really great. It shows what variants that we have currently that are circulating. So XBB.1.5 continues to be the predominant variant, but it is estimated to decrease its prevalence. But on the other hand, we do have some that are increasing in prevalence. So we have XBB.1.9.1, 1.5.1, and 1.1.6. Alrighty, and then going into the new recommendations, hopefully everyone is aware that these recommendations did change about a month ago. But currently we have 3 COVID vaccines that are approved or authorized in the United States. So Pfizer, Moderna, and Novavax. Our 2 mRNA vaccines, so Pfizer and Moderna. So as of April the 18th is when the recommendations officially changed. The bivalent mRNA vaccines are authorized for use in all age groups, so 6 months and older. So no longer authorized for use is the monovalent mRNA vaccine. So if you have any of the old monovalent mRNA vaccines, go ahead and dispose of those, as they should not be used any longer. There is an alternative option for those who either are unwilling to get an mRNA vaccine or cannot get it for some reason, if they've had a severe allergic reaction or whatnot. There is Novavax available, which is a protein subunit vaccine. It's authorized as a primary series for those 12 years of age and older, and it's authorized as a first booster only for those who are 18 years and older. As far as Johnson & Johnson or J&J, I threw this in here just for completeness, but as of May the 5th, all of the doses that were out in the field have expired and no more vaccine is going to be produced. So J&J should not be administered any longer. And if you have any of that in your fridge, please dispose of it and report wastage in Beatrix. All right, so this simplified picture here just shows where the CDC was trying to simplify this COVID-19 vaccine guidance. So as you can see on the left-hand side, there were previously 11 total products, so 5 Moderna and 6 Pfizer. They did try to simplify it, so now we only have 2 Moderna and 3 Pfizer products. Still more than I would like, in my opinion, but we do have 5 products now instead of 11. Alrighty, so just briefly, these are kind of the highlights for the guidelines for people who are not moderate or severely immunocompromised. So for our children, 6 months to 4 years of age, they are recommended to receive 2 or 3 bivalent vaccine doses. And for this younger age population, it gets kind of tricky because the guidelines are based off of not only age, but also what vaccine manufacturer they had before, as well as how many doses they've had previously. So I have some charts at the end of the this presentation. They're in our extra slides, so we're not going to go through them in detail, but I put them on there because there's some really nice graphs that show you kind of a flow chart based off of each age group. So with our children who are 5 years of age, they are recommended to receive 1 or 2 bivalent vaccine doses, again, depending on the vaccine manufacturer that's used. In general, people who are 6 years or older, who are unvaccinated or who have only received a monovalent vaccine dose, are recommended to receive 1 bivalent vaccine dose. For those who have previously received a bivalent dose, so the bivalent vaccines have been around since the fall. Nothing has changed. The composition is the same as the vaccines that we had before. So if you have anyone who's 6 years or older who has already received that bivalent dose, then they are up to date and don't need any more doses. As far as our older population, 65 and older, they do have the option of receiving 1 additional bivalent dose, as long as it's been 4 months after their last bivalent dose. And this pretty much explains what we just talked about, but gives a little bit more detail. So you can see it's based off of if they have not yet received any dose or if they have received at least 1 vaccine dose. So again, for the younger population, make sure you're looking at those charts when you have a patient that comes in, because it does get kind of tricky. For people 6 years or older, it is a little bit more simplified. So give them that 1 bivalent dose and they are good to go, at least for now. Recommend to those who have received at least 1 dose to get that bivalent dose as long as it's been at least 8 weeks since their last monovalent dose. All right, and then this is just a few bullet points here about people who are moderate or severely immunocompromised. So people who are 6 months and older are recommended to receive up to 3 bivalent vaccine doses. People 6 months or older who have already received a monovalent dose are recommended to receive 1 or 2 bivalent vaccine doses. And people who are 6 months or older who have already received a bivalent dose are recommended to go ahead and get 1 or more additional bivalent doses. So when we say 1 or more for those 6 months and older, it's really based on a clinical decision between the healthcare provider and the patient. So taking into consideration patient preference, individual risk factors, that sort of thing, people can have more than 1 bivalent vaccine dose. The CDC currently does not have a maximum number of doses that you can give to immunocompromised patients. It is really based off of the recommendation by the healthcare provider, but basically these individuals can receive a bivalent dose in 2-month increments. And again, this is just another way of showing what I just talked about. Alrighty, so we get this question a lot. So is my patient up to date with COVID-19 vaccines? So everyone who is 6 years of age and older are considered to be up to date after receiving 1 bivalent Pfizer or Moderna COVID-19 vaccine. Children aged 6 months through 5 years who got the Pfizer vaccine, if they are 6 months through 4 years old, they're considered to be up to date after receiving 3 vaccine doses, and one of those must be, at least one has to be a bivalent dose. Those who are 5 years are considered to be up to date after receiving at least 1 bivalent vaccine dose. And then looking at those younger children who have received a Moderna vaccine, they are considered up to date after receiving 2 Moderna vaccines, one of which has to be a bivalent vaccine. And again, people who are unable or choose not to get the recommended mRNA vaccine, they are considered to be up to date after receiving all of their age-appropriate Novavax doses. Looking into the future of bivalent vaccines, ACIP does have a meeting on June the 15th, and they're going to talk about the composition of the fall vaccines based off of the current circulating variants, so similar to what we do for the flu vaccine every year. The CDC and the FDA, they haven't officially announced, but they are going to discuss the possibility of having an annual COVID-19 vaccine. So more to come after June the 15th. They did also want to put out that reminder to everyone that even though they are making this decision to potentially have a new composition of a COVID-19 vaccine in the fall, they are recommending for people to go ahead and get their bivalent dose now if they're eligible, because that should not impact their eligibility to get a vaccine again in the fall. And just a couple clinical pearls with vaccination. As far as co-administration with other vaccines, in general, COVID vaccines can be administered on the same day as other vaccines. There is one thing to take into consideration. So people, particularly younger adolescent and adult males, might consider waiting at least 4 weeks if they've received an orthopox virus or mpox vaccine. So whether it was Jynneos or ACAM 2000. The only one we're giving in Virginia right now is Jynneos. Before receiving a COVID-19 because of the observed risk of having myocarditis or pericarditis after ACAM 2000. There isn't anything that we know about Jynneos vaccine. It's just a precaution based off of these side effects or adverse reactions from ACAM 2000. For those who had a history of prior infection, COVID-19 vaccine is recommended for everyone 6 months in age, 6 months and older, so regardless of their history of infection, but it is patient dependent, so looking at the level and the length of protection after the infection varies based off of people's risk factors, age, that sort of thing, and immunity does decrease with time. If someone has a recent or current infection, of course, if they are currently infected, you want to defer vaccine until that person recovers, and if they have met the criteria for isolation. For those who had a recent infection, the CDC does say that you can wait up to 3 months from having symptoms started or having a positive test. So with that being said, we get a lot of questions regarding this last bullet point as well. Should I delay or not? And it really is patient specific. So if you have a patient who is severely immunocompromised, you think that their immunity is waning, then go ahead and give them that next dose if they're due for it. I would not wait in that case the 3 months to get the vaccination. But if you have an otherwise, healthy adult that had a recent infection, then sure, you can wait up to 3 months. All right, and then just a little bit of data about our vaccine rates. In general, vaccination rates are pretty low. So that's where we as healthcare providers really can come in and continue to recommend these vaccines. So as you can see on the left-hand side, the percent of the population vaccinated with a bivalent dose increases generally as we increase with age. And then looking at the percent of populations based off of race and ethnicity, we do see the highest numbers for Native American, White, and Asian and Pacific Islander. In looking at the United States in total, overall, again, vaccine coverage is very low. Only about 17% of the total US population have received a bivalent dose. And then when we're looking at adults, about 20% of those have received a bivalent dose. And looking at age coverage, as you can see, as we get younger, our younger populations have the lowest rates. So we definitely want to recommend and target to this population. Our youngest populations, they are at risk for, hospitalization, severe illness, based on their, immunocompromised, just being, young. So we definitely want to recommend getting the vaccine for this youngest group, and then also for our highest age group amongst 65 years and older. And then just broken down based off of the United States data that we have on race and ethnicity, we see the highest coverage here amongst Asian and multiracial. And as far as take-home messages, just in conclusion, hospitalization rates and death as far as illness are decreasing. So continue to vaccinate, continue to use the therapeutics that are available to help with some of those serious illnesses. Vaccines are safe and reliable to help us build protection. The updated CDC recommendations do try to simplify the guidance for most people. Again, that youngest age group population, it does get a little bit tricky, but for the most part, it was simplified. It offers flexibility for those who are immunocompromised and also provides a customized recommendation for our youngest population. And again, bivalent vaccine uptake continues to be low, especially in our younger population. So continue to recommend that specifically for those. Patient education around this updated booster or updated bivalent vaccine. It is important to ensure that our population does stay protected from the virus, especially among those who are most vulnerable, being our youngest and our oldest population. And just as a reminder, providers who are vaccinating, if they have anyone who comes in and complains of any side effects, adverse reactions, adverse events, that sort of thing, those all should be reported, and it is required to be reported to the VAERS system, which I have hyperlinked there. And we put a few resources here, CDC and VDH. CDC has a ton of great resources. I would recommend, if you're looking for something, to go ahead and go to them first if you can't find anything there. Our website is a little bit easier to navigate, in my opinion. So you can go to the VDH website. We have a specific healthcare professionals website that is pretty easy to use and easy to find information. All righty, and thank you so much. We do have 10 minutes, or actually we have quite a long time for questions. So happy to answer those in the Q&A. I don't know if you have the option to come off mute, but if you do, feel free to do so there. And just as a reminder, you will get these slides at the end. And I do have a bunch of slides after this called extra slides there that you can see that go through a lot of important things. So once you get this presentation, these slides, definitely go through those extra slides there. And I don't see any questions right now, but if Brooke or anyone else has anything to add, I'll hand it over to you all.
This is Brooke Rossheim. I think that one thing that deserves mentioning is that the bivalent mRNA vaccines have been shown to offer added protection for children, adolescents, and adults in terms of prevention of severe illness, hospitalization, and death. And that's certainly a reason for people who have not had a bivalent vaccine to go ahead and get one.
If anyone has any questions, please feel free to put them in the Q&A. If not, we will post this online and get any questions that you all have after this over to them as well. Okay, we do have a question in the chat, Chelsea and Dr. Rossheim. And it just says, what is the difference between the 5 vaccines?
So the difference is the dosing. So if you look at some of, well, let me just go to some of these charts here at the end since we have some time. Okay. So this gives you an example. So this particular chart is showing people without immunocompromised who are 5 years of age, what's recommended. So I like this graph a lot, or this picture a lot, and they have it based off of each age group, as you can see here. But going back, just looking here at the 6 months to 4 years of age, you can see that there are different options. And so if you look down at the bottom, it gives you the concentration of each product. So based off of the age, you know, your person might need a smaller dose, they might need a bigger dose. One thing to mention too is the Moderna vaccines are a little bit tricky because in some cases they will use the same vial, but it might be a different dose. So that's why it's very important, especially in that younger population, to make sure you're triple checking the dose that you're giving and the vial specifically that you're giving as well. Hopefully that answers your question.
Thanks so much for joining us this morning. We're also going to post this on the website. We had requests for it. I know a lot of folks weren't able to make it. But we really appreciate it, and we appreciate all this wonderful content for our members. Thank you everyone for joining us, and we hope to talk to everyone soon.
Thanks everyone.
Thank you.
Bye.